Sleep Medicine, Dr. Bill Gershan. Bill is an associate professor in the Department of Pediatrics. He came here from Salt Lake City, Utah, almost 4 years ago, and has put together a great group of people in the division. So Bill is going to update us a little bit on asthma this morning. It's a very timely topic as everybody seems to have something respiratory going on right now. So Bill.
Thanks, Joe. Good morning, everybody, and happy St. Valentine's Day. Many of you might have been expecting a pediatric cardiologist today, but instead you have a pulmonologist with a red tie. So we'll go with that. These are my objectives this morning. To describe some basic epidemiological features of pediatric asthma. Hopefully, once this talk is done, you'll recognize the link between wheezing in young children and the development of asthma. To review some of the recent evidence linking respiratory tract infections and asthma. I'll be discussing the role of vitamin D supplementation in pediatric asthma. And then I'll kind of finish with a little bit about e-cigarettes in adolescents. That seems to be kind of a timely topic. Unfortunately, I have no financial disclosures, and I will not be discussing off-label use or investigational drug use. I do have a bit of a disclaimer, though. This talk will not be kind of a general review of the diagnosis and treatment of asthma. I'm not going to be doing that this morning, but hopefully talking about some of the more interesting facets of asthma that you'll enjoy. So I'm going to start off going over just a brief asthma overview, and then some of the other things are listed that I'll be discussing this morning. So the definition of asthma based on the Global Initiative for Asthma in 2016 states that it's a heterogeneous disease characterized by chronic airway inflammation and history of respiratory symptoms, including wheeze, shortness of breath, chest tightness, and cough that vary over time and in intensity, along with variable expiratory airflow limitation. And I think you'll probably understand and agree with that. Some of the more interesting facets of asthma, though, are included on this slide. It's the most common chronic disease in children. It affects about 300 million people worldwide, and estimates state that there's about 23 million people in the U.S. with asthma. It causes nearly 400,000 deaths annually. About 1% of those are in the U.S. It affects approximately 9%, close to 10% of the U.S. pediatric population, about 9 million children. It accounts for a fairly large percentage of non-surgical admissions in the U.S. in children and adolescents. The total cost of asthma has been estimated to be over $50 billion, and actually more recent studies suggest it's probably over $80 billion, at least looking at data from 2013. There may be some decrease in asthma exacerbations over the past 15 or 16 years. A recent study suggested that of those children who had asthma, about 62% experienced an asthma attack in 2001, and that number had dropped to about 54% in 2016. So perhaps it's being treated more effectively. That's a little bit unclear, but and then asthma is a disease that seems to be both underdiagnosed and perhaps overdiagnosed to some extent. There are certain gender and age differences, which are listed on this slide, there's a peak in young girls under 3 years of age, and then again in adolescents. For boys, it's a little bit different. There is a similar peak very early in life, but there's a secondary peak primary school age, between ages like 6 and 10, 6 and 12. So in that age group, in the pre-adolescent age group, boys are more likely to be hospitalized. And in the adolescent and young adult females have about a 2 times likelihood to be hospitalized. There may be some relationship to airway caliber for asthma. There are certain phenotypes that I think most of you in the audience are familiar with. Intermittent asthma usually refers to preschool children who develop a viral illness and then develop an exacerbation. Persistent, obviously, really is characterized by the absence of symptom-free periods, and then seasonal allergic asthma obviously refers to something or somebody who has some type of allergen-specific issue associated with their asthma. So I do have a few questions embedded in this talk, and we'll go over the answers, obviously, at the end, and there should be some time for questions. But the first question, and I just want to, if any of the students or residents in the audience get all these correct, I'll be asking you to consider a pulmonary fellowship in a few years. But the first question is, the Asthma Predictive Index includes 2 major criteria for assisting in the diagnosis of asthma. These include A, blood eosinophilia and an allergy to eggs or peanuts; B, wheezing unrelated to colds and allergic rhinitis; C, parental history of asthma and physician-diagnosed atopic dermatitis; D, ICU admission for wheezing and an allergy to eggs or peanuts; and E, documented RSV bronchiolitis in the first year of life with responsiveness to inhaled albuterol. So again, we'll go over those a little bit later. I'd like to spend the next few minutes just going over wheezing in young children. That's a common issue. We frequently evaluate 1 and 2-year-olds with wheezing. Is that asthma? What does that mean? So this slide kind of discusses some of the questions and issue regarding the young wheezing child. It's thought that about 50% of children experience at least 1 episode of wheezing by the age of 6. There's a number of questions that are included on here that we all, have to deal with. What is the cause of early childhood wheeze? Is it asthma? Is it something else? And that kind of leads to the hygiene hypothesis, which, as many of you are familiar with, states that early childhood exposure to infectious agents or symbiotic microorganisms like the gut flora, as well as parasites, increase the susceptibility to allergic diseases by suppressing the natural development of the immune system. And that, in particular, the lack of exposure is thought to lead to defects in the establishment of immune tolerance and possibly asthma. So, going on, what are the risks and benefits of treating early childhood wheezing? What's the best therapy for this? So these are really just some of the questions that those of us who see young children with wheezing are faced with. So this brings us to the Asthma Predictive Index, or API. And I just want to point your attention that there's the original API and there's more of a modified index. And in order to kind of use this, it's suggested that the child obviously has to have a history of wheezing and probably at least 4 wheezing episodes in the past 12 months, with 1 episode confirmed by a caregiver. And in addition, the child must have at least 1 major or at least 2 of the minor criteria, and these are obviously listed here. The major criteria, I won't go over all of these, but the major criteria include a parental history of asthma, perhaps more so in the mother, and physician-diagnosed atopic dermatitis. And then the one that was added to the modified criteria includes allergic sensitization to at least 1 allergen. And then the minor criteria are listed here. And again, initially it was physician-diagnosed allergic rhinitis, and that was changed more recently to specific allergy to either milk, eggs, or peanuts. But as you see, blood eosinophilia is important, as is wheezing unrelated to colds. So again, one major or at least 2 minor. So what does this mean? What does it matter? There's been studies over the last almost 20 years now that have looked at this asthma predictive index, and studies have shown that a positive API score by the age of 3 years was associated with a very high chance of developing asthma in the school age years, 77%, so really quite high. On the other hand, children with a negative index at age 3 had a less than 3% chance of having active asthma during their school years. So again, I think this should be used and I think can be helpful in some patients. So going on with preschool children with wheezing, this was a relatively famous study in the New England Journal about 6 or 7 years ago. Daily or intermittent budesonide in preschool children with recurrent wheezing. I just want to spend a minute or two reviewing this study. This looked at a group of kids between 1 and 4 years of age who had positive values on the modified asthma predictive index, who also had recurrent wheezing and at least 1 exacerbation in the prior year. These kids were not terribly sick. They did not have frequent problems. It was more of an intermittent issue, but they did have recurrent wheezing. So they assigned these kids to receive either a budesonide inhalation for 1 year as either an intermittent high-dose regimen, and they used a rather high dose of nebulized budesonide, 1 milligram twice daily for a week, which was started early on during a respiratory illness, or a low-dose regimen, 0.5 milligram nightly with corresponding placebos. And the primary outcome in this study was the frequency of exacerbations that required oral corticosteroids. So what did they find? This study, this graph might be a little hard to read, but the bottom line is there was really not a lot of differences. The frequency of exacerbations, and the orange bars are the intermittent regimen, so again, just used for a week when you have symptoms, versus the blue, the daily regimen. So frequency of exacerbations was quite similar. Time to the first exacerbation was really very similar between the 2 groups. Frequency of treatments was similar, and time to the first treatment for respiratory illness was also quite similar. This study also looked at the rates of respiratory illness per patient year, and that was also similar. It was about 3.3 with the daily regimen versus 3.6 with the intermittent regimen. No statistical difference. So kind of interesting. So this kind of sheds some light on maybe we don't need to use everyday steroids for those kids who are just having intermittent problems, maybe just using a week of nebulized or perhaps an inhaled steroid might be beneficial. This was a meta-analysis in 2016 in Pediatrics This looked at children under 6 years of age who had at least two wheezing episodes in the past year. Again, the primary outcome was exacerbations that required oral corticosteroids. They included a lot of studies here, 22 studies, over 4,500 children were included. And this is just kind of a summary of what they found. In 15 studies with over 3,000 kids, they compared daily inhaled corticosteroids with placebo and found that daily inhaled corticosteroids reduced exacerbations fairly significantly. So the relative risk was 0.7, which means that the daily corticosteroids decreased the incidence of these exacerbations by about 30%. So fairly significant. There was one study in 200 kids that found reduced exacerbations with daily inhaled corticosteroids versus Singulair, a medicine that we occasionally use, about a 40% decrease. And then there were an additional 5 studies in a fairly large number of kids with intermittent asthma or viral triggered wheezing that showed decreased exacerbations, again with an intermittent high-dose inhaled corticosteroid versus placebo, and again, about a 35% drop. So this study suggested that daily inhaled corticosteroids were probably indicated to prevent exacerbations in kids who had more recurrent wheezing or persistent asthma. But in those children who only had intermittent problems or viral triggered wheezing, a couple times a year, the intermittent inhaled corticosteroids might be just fine. And that is something that we've certainly incorporated in our practice over these last 5 or 6 years. This is the infant study that I think bears some, at least a summary, standing for individualized therapy for persistent asthma in young children. It was a multi-center randomized double-blind study looking at kids 1 to 5 years of age with asthma who required a daily controller medication. And they, again, it was a 1-year study that looked at 3 periods, 4 months each, and children were in each of these periods, they were either on a daily inhaled corticosteroid, a daily leukotriene antagonist, Singulair, or as needed inhaled corticosteroids with albuterol. And the majority of children had a significant and different response to one of these treatments. The probability of the best response was highest to the daily inhaled corticosteroids and was predicted by sensitization to an allergy. And this was even further increased if you had additional eosinophilia, which I'll kind of review in this next slide. So this looks at, again, the bars, the pink bar are daily inhaled corticosteroids, the blue bar is the as-needed inhaled corticosteroids, and the yellow is the daily leukotriene antagonist Singulair. And it divides patients that were not sensitized to an allergen versus those who were sensitized, and also looks at the peripheral eosinophil count, either less than 300 or greater than 300. And as you see here, probably the best response for decreasing exacerbations was in those kids who were both sensitized to an allergen with eosinophilia. Again, daily inhaled corticosteroids. And use of daily inhaled corticosteroids, at least in this study, resulted in more asthma control days and lower asthma exacerbation risk. Now, that being said, if you look at these, closely, you might say, well, in this group, maybe the as-needed inhaled corticosteroids were better, those kids that were neither sensitized nor had eosinophilia. But again, those that had both, clearly daily inhaled corticosteroids were the best. This looks at some of the older studies using inhaled corticosteroids. Now, this is for asthma prevention, and I don't want to go through all these studies. For number one, it's a little bit too long, and number two, these are kind of older studies. These are all about 10 years old. But to suffice it is to say that these, again, were use of typically either inhaled or nebulized steroids very early in life in kids who either had a risk of wheezing or there was a strong family history of wheezing. And the bottom line is that we could not prevent asthma by using these medications very early on. There was really no difference in risk, whether we use them or not. So, and that was just last year in the journal Lancet. So, this article also came out last year. This was a kind of a suggestion, an approach to those children who have either intermittent problems with wheezing or persistent problems, and it divides the intermittent kids into those with a negative modified asthma predictive index versus a positive API. Those who have intermittent disease with a negative API, there was some suggestion of using courses of azithromycin. Now, that's a little beyond the scope of this talk, but there might be some benefit in using a course of azithromycin in those kids, perhaps as an anti-inflammatory agent, a little bit unclear. But again, these are relatively short courses. In those with intermittent disease with a positive API, again, we keep on getting the same theme of using intermittent inhaled corticosteroids. There may be certain groups, though, that respond better to inhaled corticosteroids, and those include boys, those who are Caucasian, those with more symptoms or hospitalization or who are sensitized. And in those cases, in those groups, daily inhaled corticosteroids might be more effective. And then certainly with persistent asthma, as we just saw on one of the previous slides, if you have both allergy sensitization and eosinophilia, daily inhaled corticosteroids are probably more beneficial versus if you don't, then other treatments, either possibly daily or singular or symptom-driven steroids. This article also looked at the utility of oral corticosteroids for acute wheezing and asthma exacerbations in preschool children, and the utility of this is still somewhat unclear. A recent meta-analysis showed that oral corticosteroids did not prevent either hospitalizations or emergency room visits in this population. And this is just a slide, kind of a reminder. I think for the residents, I think they're quite familiar with this, but it looks at the asthma severity classifications according to the National Asthma Guidelines. This is 10 years old now, but still I think is helpful. Obviously, severe, persistent, you're having frequent, continual symptoms, but I just want to point everyone's attention to, we talk a lot about persistent versus intermittent, and I think the number to remember is 2. If you have more than 2 days with symptoms per week or more than 2 nights per month with symptoms, that kind of puts you in the mild persistent range versus if you have 2 or less of those symptoms, either days with symptoms per week or 2 or less nights with symptoms per month, that would classify you as mild intermittent. So I think that number 2 is helpful to remember. We've also included pulmonary function tests in this. We usually start doing those at age 5, sometimes age 4 in a very cooperative child. And those are included here, so FEV1 or peak flow. I don't, others may want to comment later, but I haven't honestly found those real helpful in determining this classification. I think it's really more based on symptoms than anything else. But we certainly do obtain spirometry when kids are able to do that. So that brings us to the next category that I'd like to just talk about for a few minutes, and that's respiratory tract infections and asthma. Kind of an important topic these days, especially with influenza. And that brings us to question number 2, which is wheezing episodes caused by which virus is most associated with eventual development of asthma in children? RSV, parainfluenza type 3, rhinovirus, influenza B, or adenovirus. So mark in your answer. And again, we'll go over those at the end. So there's a lot to be said about respiratory infections and asthma, and a lot of factors which are listed kind of nicely on this slide. Obviously, the actual virus is important, rhinovirus or RSV, and you might say, well, why are those just listed? And you'll find out in the next few minutes. Pre-existing airway inflammation, genetics is certainly very important if one or both parents has a history of asthma or atopy. And there's certainly genes that I'll show you a little bit later. The microbiome is getting more and more press, I guess, and both the airway and the gut microbiome early in life may affect the development of wheezing and asthma later in childhood. And the treatment, as we'll see, rhinovirus-associated wheezing might be more responsive to oral corticosteroids, whereas RSV-associated wheezing is probably less responsive to oral corticosteroids, and other treatments might be helpful. It's also known that viral wheezing illnesses might damage the airways and cause airway obstruction. And then lastly, the environment is clearly important, whether there's exposure to cigarette smoke, airway pollution, and certain allergens. So that's incredibly important in the development of asthma. So there's a number of things that are known, and I kind of wanted to summarize those on these next couple of slides. We do know that preschool children have, on average, I've read some places where it's 5 respiratory tract illnesses per year, maybe as many as 7, but it's a lot. And it's actually rhinovirus-induced bronchiolitis with wheezing seems to be a more helpful marker of asthma risk than is wheezing caused by either RSV or other viruses, and that was noted in the COAST study. And that study found that the risk of asthma by age 6 was increased if the child had wheezing with rhinovirus. The odds ratio for that was about 10, so 10-fold increase, as well as RSV. The odds ratio with RSV was only about 3, and the odds ratio for other viruses really was not much above 1. So rhinovirus by far, RSV probably number 2. And the other thing about rhinovirus risk of asthma is that if you also have a concomitant allergen sensitization, that certainly markedly increases your risk of developing asthma. Interestingly, one of these references, I can't remember which one, but one suggested that this viral-associated asthma risk may last for 15 years or more. So it's not just, if you've had a recent virus, but it can last for quite a while. And in addition, we all know that in children with asthma, viruses, especially rhinovirus, contribute to many, if not most, of the acute exacerbations that kids get. So we talked a little bit about rhinovirus. RSV is also linked to increased risk of asthma. I think the severity of RSV, though, is quite important. So a more severe RSV infection, if you're hospitalized, that certainly increases the risk. There's certainly interaction between viruses and bacteria, and that's being kind of explored right now. And Many of the exacerbations caused by viruses are multifactorial, with a number of things that we talked about on the prior slide involved in that. What about our rhinovirus versus RSV-induced wheezing? And again, we're seeing a fair amount of both of these illnesses in the hospital, probably more RSV in the winter. And this slide just compares kids with rhinovirus-induced wheeze versus RSV. Rhinovirus tends to be older, which makes sense. RSV is generally a more severe illness with younger children. Children with rhinovirus are more likely to have wheezed previously. Again, more often have some type of allergy, seem to have a more favorable response to oral corticosteroids versus those with RSV. And it seems like rhinovirus might be less severe than RSV in infants, though actually the development of wheeze may be more rapid than those with RSV. So kind of an interesting fact. We've said that there are a number of genes or gene products that seem to be associated with both RSV, bronchiolitis, and wheezing, and the subsequent development of asthma. And I won't say probably more about that right now, but just know that there are. And then what is still unknown? There's a number of things that are still unclear, which are listed on this slide. The questions are, does rhinovirus cause asthma or unmask asthma? And I think the big question is, if we prevent some of these viral illnesses from occurring in infancy, will that ultimately change the rates or reduce the rates of childhood asthma? And then lastly, could the number of viral illnesses early in childhood be related to the development of asthma? Not just the virus itself, but the number. And I know this is a very busy slide, but this was a study a couple of years ago looking at both virus-specific causes, but the take-home point is circled in red here, where these authors did conclude that, and this was in the Copenhagen prospective study of asthma in childhood. They looked at over 300 children who were followed prospectively. They found 9 viruses and 3 bacteria in the airway secretions during lung infections during the first 3 years of life, and then looked at the development of asthma at age 7. And interestingly, they found that this looks at the total number of respiratory episodes adjusted for the number of respiratory episodes with each agent. So that was very significant. This all means that there's a 40% higher chance of developing asthma by age 7. So perhaps the number of viruses and not only the specific virus is important. There's a number of opportunities for treatment and prevention of virus-induced wheezing, which are listed here. And again, we're looking mostly at rhinovirus and RSV. Vaccines, probiotics, bacteria may also be involved, so antimicrobials might be important. Even a new class of probiotics might be selected to promote resistance to viral illnesses. And then we certainly use omalizumab, Xolair, for those kids with severe asthma and allergy. Could other similar medications be helpful? I'll talk a little bit about some other medications at the very end of this talk. Certainly inflammation is also important, and could new types of inflammatory agents be helpful in preventing this really cascade to resulting in wheezing. I'm going to spend just the next few minutes or so discussing vitamin D supplementation. I think there's been a lot discussed about that in these last several years. Again, we have a question. The increased prevalence of vitamin D deficiency is most related to A, decreased intake of vitamin D containing foods, B, obesity, C, use of sunscreen, D, viral illnesses, or E, decreased sun exposure. Remember your answer. This is a slide of vitamin D physiology. You might wonder, why is a pulmonologist going over vitamin D physiology? But I think it's kind of important. The vast majority of active vitamin D, that's the 25-hydroxy vitamin D, is caused by exposure to sunlight and then reactions in the skin, basically. A small amount of active vitamin D is through foods, which orange juice, dairy products, fish, but by far most is related to exposure to sunlight. And we do know that the prevalence of vitamin D deficiency has been increasing in the general population over the last probably 30 or 40 years. And this increased prevalence is thought to be basically sun avoidance. We tend to stay inside, we have an indoor lifestyle, we use sunscreen, and perhaps less related to decreased intake of foods that are rich in vitamin D. Another factor that might relate to this is vitamin D is sequestered in adipose tissue, and the increasing prevalence of obesity might also increase the prevalence of vitamin D deficiency in the general population. So there's a number of effects of vitamin D on the respiratory system, which are listed here. And specifically on asthma, there's many. I won't go over all these, but I want to just point out a few. It is known that asthma exacerbations caused by virus tend to increase production of cytokines, which are pro-inflammatory, including IL-17A. These cytokines seem to exacerbate allergic airway responses. And then there's probably vitamin D also helps to maintain this Th1, Th2 balance, which can either favor or decrease the chances of developing asthma. It also might assist in reducing airway inflammation. And then vitamin D also helps to regulate fibroblasts and increases production of matrix metalloproteinase, which influences the function and migration of inflammatory cells in the body. And prior studies have noted that low levels of vitamin D are associated with increased risk of asthma exacerbations in both children and adults. And I'll go over a few of those studies now. This was a meta-analysis looking at, in Lancet, this looked at double-blind placebo-controlled trials of vitamin D supplementation on subjects who had prior asthma. And the primary outcome was the incidence of asthma exacerbations that required oral corticosteroids. They did a subgroup analysis looking at baseline vitamin D levels. And I don't know if you can read this from the back, but they looked at a huge number of studies, 776 studies. They had to exclude many of them, most of them, and they were left with 8 eligible studies with over 1,000 participants, and they had to exclude one of those. So 7 studies, close to 1,000 participants that they could examine. And I'm just going to, again, spend a few minutes talking about some of these studies and how vitamin D might be good if you have asthma. So this is kind of a summary of those, of that study. And just in terms of, who was included in each of these cases, this Castro included only adults. The second study was primarily adults, and these last 3 were children. And you can see this is the relative risk. So it did appear that using vitamin D to prevent exacerbations was effective looking at all these studies together. The relative risk ratio was 0.69, so again, about a 30% decrease in exacerbations. So fairly significant. There was no significant difference between vitamin D or placebo in the proportion of patients who had at least one exacerbation or time to the first exacerbation. Now, they also looked at the levels of vitamin D, which are listed here, less than 25, 25 to 50, et cetera. And so this was looking at the adjusted exacerbation rates based on the initial level. It was best, vitamin D was most effective, which kind of makes sense, in those patients who initially had a very low vitamin D level of less than 25. Decreased, looks like by about 60%. Less so if your vitamin D level was mildly decreased or normal. So again, perhaps suggestive we should use vitamin D in those kids who are vitamin D deficient with asthma. This is a number of other studies, again, specifically pediatric studies, another meta-analysis in pediatric asthma. They used, these were again randomized controlled studies. They used a vitamin D dose of at least 500 international units per day, and 5 of these studies met the criteria. And again, really similar findings. Again, this is just pediatric studies. With a fairly significant decreased risk, almost a 60% decrease in the exacerbations. There were a few problems with this study. They couldn't do meta-analysis of pulmonary function tests and asthma symptom scores, and many of these studies did not include adverse effects, or adverse events. So again, vitamin D probably helpful in those asthma children who have low vitamin D levels. I'm going to spend a few minutes talking about e-cigarettes, because that was kind of an area I honestly didn't know real much about. Again, question, which is a true statement regarding e-cigarette use in adolescents? E-cigarette use has decreased in recent years. E-cigarettes typically contain a battery and an atomizer. Conventional cigarette use is more common than is e-cigarette use in adolescents. E-cigarette use is significantly higher in non-asthmatics versus asthmatics, and e-liquid is thought to be safe other than the nicotine it contains. So, what is known about e-cigarette use? Cigarette smoking in adolescents has decreased in the past decade, as it seems to have in the general population, at least to some extent. However, the use of e-cigarette use has really increased dramatically in this past decade, enormously. And the thought is that e-cigarette use is now about twice that of cigarette use in adolescents. And one study that is listed here suggested, unfortunately, that the prevalence of e-cigarette use may actually be higher in adolescents with asthma, perhaps because kids with asthma might believe it's a safer thing to do than to smoke a cigarette, but could even be higher. So this was a study, well, actually more of an evaluation from the CDC, looking both at current use of e-cigarettes at various ages versus ever used, looking at different time points. But as you see, it's not insignificant even in middle school students. It's 4 or 5%. It jumps up to 13 to 16% in high school students and then kind of drops off. Ever used is about twice that. So, 10% to 12%, middle school, perhaps as high as 30% in high school students. So this is not a small issue. And again, it appears, if you look at the years, that there's perhaps some increase, at least from 2014 to 2015. This was a bit of an eye-opener for me. There's many different types of e-cigarette products out there. This basically looks like a pipe. I thought this one kind of looked like an inhaler, a regular inhaler, which is interesting. And then you have disposable e-cigarettes, rechargeable e-cigarettes. There's actually hundreds of brands of e-cigarettes on the market, hundreds, and probably not terribly difficult to obtain. What are the components of e-cigarettes? They all contain a battery, an atomizer, a tank or cartridge to hold the e-liquid, and then the e-liquid has a number of constituents which are listed here, including nicotine and flavoring agents. The battery is usually a rechargeable lithium battery. The atomizer is of various construction, and the battery output and the resistance of the heating coils help determine the voltage and temperature range. And the temperature range kind of affects the decomposition of the things in the liquid, which can be toxic in their own right. And some of the newer models allow the user to manually increase the voltage and increase the temperature. Again, perhaps causing more toxic materials to be emitted. There are a number of biological effects of exposure to chemicals in e-cigarettes, and again, these are kind of divided with the main constituents of the liquid, propylene glycol and vegetable glycerin, some of the flavoring agents, and nicotine. I think we know probably more about nicotine than we do some of the other things, but looking at the major constituents of the fluid, they help keep the nicotine and the flavoring agents in suspension and maintain moisture of the solution. These are thought to be safe for oral consumption, but unclear about when they're inhaled. We're kind of learning more things about them. There are certainly some acute exposure effects that are listed here: coughing, dry throat, chest tightness. Chronic exposure, a little bit less known at this point. There's been some data about workplace exposure. Some of the flavoring agents, people thought those were fairly benign, and as a matter of fact, flavoring agents are banned in regular cigarettes due to the potential enticement of children. For some reason, they're allowed in e-cigarettes. So, kind of think about that one. I don't know. And then there are certain receptors that may be upregulated by some of these flavoring agents, and these these agonists are in certain flavors, cinnamon, mint, clove, that may cause certain pulmonary reflexes and side effects. Chronic exposure a little bit less clear. And then some of these are also upregulated in viral infections. There is really no long-term data that exists on the potential long-term effects of e-cigarette use and possible links to childhood asthma. This was kind of an interesting study that really just appeared in January of this year in Pediatrics, the trajectories of e-cigarette and conventional cigarette use among youth. They looked at students at 3 high schools in Connecticut in the years 2013, 14, and 15, and they wanted to explore the relationship between past month cigarette and e-cigarette use over time. And they looked at a number of covariates: age, gender, use of other tobacco products, ethnicity, etc. And, they looked at quite a few number of patients, over 800. Now, I shouldn't say patients, but students. So I thought these results were really quite interesting. Past month e-cigarette use was very highly predictive of future cigarette use, with odds ratios, depending on what period you looked at, of approximately 7 or 4. So again, if you used e-cigarette use, you were much more likely to eventually use regular cigarettes. But the converse wasn't true. So past month cigarette smoking was not significantly predictive of future e-cigarette use. And the use of both things, both e-cigarettes and cigarettes, really increased over time, so that about a quarter of the users reported using these one or both of these things the majority of the month during this past month of investigation. So a report just came out approximately just a few weeks ago, actually. The National Academy of Sciences released a report, and you might argue with one or two of these points, but they did state that vaping with e-cigarettes that contain nicotine can be addictive, and that teenagers who use these things may be at higher risk of smoking. That seems to be true from that study in Connecticut. The second point, you might raise some hairs. It's thought that these devices are safer than traditional smoking products and may help smokers quit, at least in those who smoke and try to switch to them. It can be helpful and probably decrease the exposure to some of the more toxic things in cigarette smoke. There's no long-term scientific studies on the device's addictive potential or their effects on the heart, lungs, or on reproduction. Vaping may prompt teenagers or young adults to try regular cigarettes, putting them at higher risk for addiction. But any linkage between e-cigarettes and long-term smoking hasn't been established. And there's no evidence, at least at this time, that e-cigarettes cause cancer, though I'm not so sure they've been around long enough to determine that. They're not thought to have carcinogens in them. This brings us to the last question, and just a few more slides in the talk. Which of the following new asthma treatments is approved for children under 12 years of age? A, bronchial thermoplasty, B, benralizumab or Fasenra, C, mapolizumab or Nucala, D, reslizumab Cinquar, and E, none of the above. And I did have to practice those names quite a bit. So again, I'll finish up just with a few slides of potential new asthma therapies. So what about bronchial thermoplasty? As the slide says, it's a novel therapy that was approved in 2010 and really just for adults with severe asthma. It's thought to reduce airway smooth muscle mass using thermal energy. It's usually done in a series of 3 bronchoscopies. You can't do all at the same time. I've been told that patients can develop asthma exacerbations after this is done. And they have found that there's decreased asthma exacerbations, about a 32% decrease, as well as improvement in asthma symptoms and quality of life. There's been variable improvement in pulmonary function without any long-term negative effects. There seem to be some improvements in airway responsiveness to methacholine after bronchial thermoplasty. So again, a treatment for asthma. I just wanted to show this 2-minute slide, which is kind of a nice...
With normal breathing, the airways of the lungs are fully open, as in this cross-section of an airway. People with severe asthma have more airway smooth muscle circulations. This excess muscle, together with inflammation of the airways, combines to make the airway walls thicker than normal. During an asthmatic attack, in response to an asthma trigger, such as an allergen or irritant, the airway smooth muscle contracts, leading to airway narrowing and breathing difficulties. During bronchial thermoplasty, a small flexible tube is advanced into the airway through a standard flexible bronchoscope placed through the mouth or nose. No incision is required. The Alair device has an expandable wire electrode array at the tip, and when it is expanded, the four arms of the electrode array come in contact with and fit snugly against the airway wall. The expanded electrode array will then deliver controlled radio frequency energy for about 10 seconds to heat the airway smooth muscle. About 1/3 of the targeted lung areas are treated during a single procedure. A total of 3 procedures are currently needed for complete treatment. Once the procedure is completed, the device and the bronchoscope are removed. The controlled energy delivered during bronchial thermoplasty creates mild heat within the airway wall that is designed to reduce the amount of airway smooth muscle. By reducing the amount of airway smooth muscle, the procedure reduces the ability of the airway walls to contract and narrow during an asthma attack.
So, interesting. Again, not used in children, but used, I guess, quite fairly frequently on the adult side by one of their invasive pulmonologists. So I just want to spend the last minute or two of this talk going over some of the newer anti-eosinophil drugs for asthma. It's kind of a nice timeline here. Back in 1949, cortisone was developed. IgE was kind of found in the late 60s. Inhaled corticosteroids came on the market in the early mid-70s, so they've been around for a while. In the 90s, some of the interleukins were found, including IL-5, which is kind of what many of these current medications are being used to inhibit. Omalizumab, also known as Xolair, is been around for over 10 years now, which can be quite helpful in children with very severe asthma with allergy. It's usually an injection every 2 to 4 weeks to help control their symptoms. And then these 3 drugs, which I'll just briefly discuss in the next slide, have all been developed in the last couple of years, with others kind of out on the market or being experimented with. And this just kind of summarizes these 3 anti-eosinophil drugs for asthma. They all work by blocking IL-5 or inhibiting IL-5. Unfortunately, none are approved for kids under 12. These are all medications for over 12 or over 18. I'll explain why this one's a little different. And then the dosage is different, from sub-Q every 4 weeks to IV every 4 weeks. This most recent one, benralizumab, initially can be given every 4 weeks and then every 8 weeks. They all seem to decrease asthma exacerbations fairly significantly, by perhaps 50%. Reslizumab, however, in those studies, the asthma exacerbation rates in adolescents actually doubled using this. So that's why this medication is not approved for over 12. And then there's a difference here in the rate of decreased asthma exacerbations, really based on the baseline eosinophil level of benralizumab. So that is a factor there. And they all have kind of small, probably not very significant changes in pulmonary function testing. So just kind of a word about some of these newer medications that are out there. We can use 2 of them in our older patients, but they're primarily used for adults. Well, I think that concludes my talk. I think I'm just going to go over the answers real quick. And then there might be a few minutes left for questions. So again, the Asthma Predictive Index includes two major criteria. These include, any takers out there? I hear mumbling. Yep, C. Good. Rhinovirus, right? Probably not C, right? E, yeah. B, yep. None of the above, right? So, happy Valentine's Day, everybody. Thanks for attending. Any questions? Tom?
Thanks for Could you comment on the use of nebulizers versus spacers? The Twin Cities are a very heavy nebulizer use, but I thought there were data that came out 20 years ago that the spacer is a more effective delivery tool for medications.
Right. I mean, we typically do use spacers in the vast majority of kids. I think we might start off using nebulizers at a very early age, maybe in the first year or two. There's not a huge amount of data out there in that age range. Some kids do fine with inhalers as babies. I guess there's personal experience. I say there's a number that don't tolerate inhalers very well at that age, but I try to switch everyone over by age 2 to inhalers. And you're right, they are certainly as effective, if not more effective. Gail.
I just want to make a comment for the residents about the azithromycin. I've sort of been on a rant about this, because there is some local practice about starting kids on azithromycin 3 times a week as an anti-inflammatory. And the study that Bill cited actually was not that. It was really looking at lower respiratory tract infections, and the treatment was azithromycin for 5 days only at the beginning of a lower respiratory tract infection to try to prevent progression to more severe symptoms. And I think that when looking at this azithromycin 3 times a week as an anti-inflammatory, it's like everybody is giving that for everything. We've seen that for try to prevent BPD, try to prevent asthma, try to do this. I think in the spirit of antibiotic stewardship, I think we need to be really thoughtful and not just say, oh, we're using it as an anti-inflammatory. I think the other piece is that Bill didn't have time to get into is that there are different phenotypes of asthma. There's eosinophilic airway inflammation and neutrophilic airway inflammation. And what we don't know is which treatments address which inflammation better. So more to come on the science, but I just wanted to say that about the azithromycin because I've just been seeing a lot of it.
Yes, I agree, Gail. Thanks for those comments.
So I had 2 thoughts. One, maybe we can get budesonide in the e-cigarettes, and then the asthma patients will do okay.
Yeah, maybe.
It's got to be heat stable. And then my second real question is, you talked a little bit about budesonide, and I know some of our colleagues at Children's are using it in the acute emergency department setting as part of their duoneb with Atrovent, albuterol, and then budesonide. And I looked at the literature, and it looks like it might help symptoms a little bit, but it doesn't change the admission rates or anything. And
no, it's not going to have any acute effect. So.
That actually,
I have a question about your. Do you want to say something?
No. I'm not sure how effective it's going to be, honestly. And I think an oral route or IV route is certainly going to be much quicker.
I have a question about the young child wheezing point you had. And, we're in the middle of the bronchiolitis season, and we have guidelines that state for bronchiolitis, nebs don't work, steroids don't work, suck out their nose, give them oxygen and positive pressure if they need it. And I largely believe that, especially in the first season or the first year of life. But what about the second year of life? It's still bronchiolitis. I can't tell you how many of my patients come to us. Yeah. They're getting nebs, they're getting steroids, and I'm like, stop the madness. But I'd like to hear what you think.
I don't know. I think if they just have, one severe illness each year, that's hard to say that's asthma. So I don't know how helpful it's going to be. I think and the guidelines, as you know, don't suggest using many of these treatments, so we don't have much. We want to do something that might help, but quite honestly, in the vast majority of patients, these things don't help if they're isolated illnesses.
So our time is up, so if you have further questions, feel free to come forward.
You have been disconnected from the meeting.